Hi everyone, my name is Brent.
Hi, Brent.
I am not an addict. Well, this is it. All right.
Yeah.
Anyways, so we're gonna go over just some super basic cardiovascular emergencies. Nothing crazy. More discussion, open floor topics. I don't want this to be like I'm over here telling you this is how everything is. We all know how diverse cardiovascular emergencies are and how much is to it. So feel free to jump in, especially because everybody's seen something or experienced something in the field. If you have a little time on the floor, even you guys that are a little newer, you guys are already seeing it. The cardiovascular emergencies are so diverse, and there's so much to it between coronary arteries, the atrias, the ventricles, the conduction system, right? So let's dive into it. If anybody has good stories, anything to add, please feel free to jump in. Tell us your experiences, the signs, symptoms, how you treated it. And then we'll kind of jump into a little bit of like electrocardiograms, mostly for the basics. Your guys' role is not, I think, at times treated serious enough. And I don't mean that as an insult. I mean that in a way that you guys are more important than you know. Because we're stepping back, looking at the bigger picture, and trying to see overall what's going on. Where you guys are in there, you guys are putting on the 12 leads, you guys are putting on the vitals, so we can see ultimately what's going on deep down into this person. And if that equipment isn't placed properly, sometimes it can change the outcome of how we interpret those electrocardiograms or vital signs, right? So let's get into it. So just the basics, coronary vascular disease. It's ultimately referring to the heart and the blood vessels. All right. So if you hear somebody say that, especially at the hospital or a patient, and believe me when I say, we all know when we were new, somebody would say something, especially a patient, and we're in the back hitting the next tab, Googling it, trying to figure it out so we could understand what it was, so we sound like we know what we're talking about with the patient. Ultimately, we should have a good base knowledge. There are those times that we are going to have to relate, and we don't ever want that patient to feel like we are incompetent in doing our job, right? So don't be afraid to look things up. It's very important. And then coronary heart disease, we're talking about the coronary arteries, and those are the arteries that run through the heart. There's multiple coronary arteries, and that is ultimately where you're going to find your myocardial infarctions. Super quick share story, because I want to get through this fairly quick because the next presentation is even better. So I had my OMI clinical, and they pretty much fillet up the heart like a filet mignon, nice cut of meat, and they had some calcification of the coronary arteries, and I got to see the calcification in those coronary arteries. It is mind-boggling how that person probably lived as long as they did. Is pretty crazy. So that when we hear people talk about, plaque buildup, calcification in those coronary arteries, they are detrimental to those people's health, and we start thinking about how much healthier we need to be as individuals, right? AMI, right? Acute myocardial infarction, probably the number one thing we're looking for when we go on to chest pain call. That's why we're hooking up the 12 lead. We're trying to see if there's elevation in those leads and trying to diagnose what's going on with that patient. It's basically narrowing or blockage of the coronary arteries and tissue death. Tissue death is a key indicator that something bad is going on, and there's multiple ways to interpret that for the medics that are looking at those 12 leads, as they all know. So a little A and P here, structure and function, the cardiovascular system composed of the heart and blood vessels, and it's oxygenated blood and nutrients to the cells, and hormones and waste product and disposal sites, right? So that blood is moving all over our body between our liver and our gallbladder, which is holding our, help me out.
Waste products.
What's that?
Or your waste products.
Waste products, thank you. So ultimately it's holding onto our waste products as well. We have our We have our spleen that's holding all that blood. So that blood is moving throughout all of our organs, throughout our heart, through our lungs, through our brains. So it gets pretty diverse, right? So when we start talking about cardiovascular emergencies, that is multiple things. Going back to the heart here, basic, let's keep it super basic here. We have 4 chambers, right? We have our right atrium, our right ventricle, our left atrium, and our left ventricle. And there's just some good pictures of it for you. Your aortic arch right here. Keep this in mind. We're going to get into a little bit of the baroreceptors and chemoreceptors, which ultimately controls those hormones in our body and regulates, vasoconstriction, vasodilation, and blood pressures, and all that good stuff, right? So right atrium receiving blood low in oxygen from the superior vena cava, inferior vena cava, and the coronary sinus. That's super important to keep in mind. So we look at the heart and we think of it's just a pump, but you also have to think about all the pipes connected to it. Those pipes are going to affect the rest of the body. So if you start seeing somebody with mottling, some cyanosis in certain parts of the body, you have to think about clots, right? Maybe Damien went into shock in the last presentation. And we start thinking about aortic dissections. Going to the left atrium, oxygenated blood from the lungs via the right and left pulmonary veins. So pulmonary veins, pulmonary arteries, if you guys remember back to basic class, they're switched, right? Your pulmonary veins are your oxygenated blood, and your pulmonary arteries is your deoxygenated blood. Right ventricles, left ventricles, deoxygenated blood to the lungs from your right ventricles, and your left ventricles pumps oxygenated blood throughout the body. Okay, so thinking about the left side of our heart, super important. Our left side of our heart is pumping our blood systemically throughout our body. So when people have left heart failure, it is a big deal. Okay, and we'll get into it a little bit deeper here shortly, but think CHF, right? The septa separates the heart into 2 functional pumps. So you have your right heart and your left heart. The right atrium, right ventricle, which we went over. It's your low pressure system. That is going to be your pulmonary circulation. We don't want to overthink this. Let's keep it kind of in layman's terms. So low pressure is the lungs, and left heart is going to be systemic circulation, like we just talked about. It's high pressure systems. Myocardium is the middle layer of the heart. We have our endocardium, which is the inner layer, and then we have our pericardium, which is the outer layer. Why is myocardium the only one I put on here? Because myocardium is the muscle of the heart. That's where you're going to see your tissue death, and ultimately where what is affected when your blood flows, your conduction systems working through your myocardium. When you think about ischemia for the heart, it's affecting your myocardium. Our heart is basically a giant muscle at the end of the day. As we talked about earlier too, coronary arteries. Left main coronary artery supplies the left ventricle into the interventricular septum. And then the right coronary artery supplies right atrium, right ventricle, parts of the left ventricle, and portions of the conduction system. So if we're thinking about right coronary artery, we're thinking on the medic level, not to jump too far ahead here. What is that right coronary artery supplying that ultimately gives us blocks in a certain area, and we're thinking about conduction and our heart rate? SA node, AV node. So everything, we start thinking about heart blocks. And I'll tell you right now from my experience of transporting out of regional a lot, anybody who has a right coronary artery blockage, they'll be thrown into a lot of lethal rhythms. The one I've seen the most is idioventricular rhythms. and it is pretty significant, even when you're fluid bolusing them. And that particular case, where I had one, the guy, they were suspecting a brain bleed. They weren't running heparin, and there was no aspirin on board either. But he went into IBR in a rate of I think 33 at one point, but it was very wide, no P waves. Cardiac cells have 4 properties that help the heart function. Myocytes are your cells in your heart. They're extremely important. That's probably one of the most important ones you'll think about when you think about cardiac cells. You have your automaticity, excitability, conductivity, and contractility. Contractility is the one we probably hit on the most when we're talking about pressors. So we think about our epinephrine. It works on alpha and beta receptors, and so alpha is you're working mostly on your veins. You have your beta 1, think about heart. Beta 2, you have 2 lungs, right? You have 1 heart, 2 lungs. So keep that in mind when you're thinking about epi. Epi is ultimately keeping that blood flowing because we want to keep that blood supplied to the brain, ultimately, but also the heart and the lungs, because it all works in function, right? It's all connected. The conduction system comprises of 6 parts. We don't need to get super crazy into this, but ultimately, going back to basic school, right? We think about SA nodes, AV nodes, and the bundle of His, the Purkinje fibers, and different rates. Your SA node 60 to 100, AV node 40 to 60, the bundle of His. So think about it like this. It starts off at your SA node, and it's getting slowed down going through your AV node, right? That's ultimately what the AV node is doing. It's slowing down your heart rate, because if we go and hit those Purkinje fibers and those bundle branches, and we're starting to create like a super fast heart rate, and ultimately we want everything firing in sequence. So it's slowing down as it's going down the interneural pathway. Nerve stimulation, stimulation of the sympathetic nerves strengthens the force of contraction, increases the heart rate. This one is, we're going to elaborate more on this. Let's go forward. And the parasympathetic nerve slows the rate of discharge of the SA node, slows conduction through the AV node, weakens the strength of the atrial contraction. A little bit of just what I talked about, can cause a small reduction of the force and the ventricular contraction. Acute coronary syndromes, a series of cardiac conditions caused by an abrupt reduction of blood flow through the coronary arteries. All right, so this is kind of where I want to get into it a little bit more. We think about stable angina, unstable angina. There's things called Prinz metal angina. Nothing we truly need to worry about, okay? This person is having chest pain, all right? We're thinking, ultimately, the person has chest pain. We need to do a 12 lead, right? We all know that at this point. They have chest pain, 12 lead, make sure they have allergies, get aspirin on board. For those intermediate and up, we're thinking Mona, Fona. Ultimately Fona for us because we carry fentanyl. I'm telling you right now, just because there's not elevation does not mean they are not having a heart attack. Okay? Chest pain is taken serious for a reason. The only way to know is to go get labs done. They're going to run troponin levels. I've seen people with troponin levels of 90, they found an infarct when they went to cath lab. And I've seen people with troponin levels of over 400, they didn't find anything. So, and those guys, both of them, I actually took them back to back. I stayed for each cath just briefly. And they both were super healthy individuals. But one person, their life was changed forever because they caught it. The other person, they didn't find anything, thank goodness. So make sure we take chest pain serious. We should be always trying to transport anybody with chest pain. There should be like, oh, your 12 lead looks good, and I know you're having some chest pain, but I think you're all right. No, we have to transport, all right? Obviously, we run that criteria. The patient doesn't have a right to refuse. Anybody with chest pain and they're refusing, I'm calling consortium. All right, call consortium. Say, hey, explain the situation. I don't have these findings. What is this patient presenting like? Okay. How long is the chest pain? Well, your OPQRSTU, right? What were you doing when it started? Okay. Anything make it better or worse? Okay. Describe your chest pain. Does it radiate anywhere? Right? When you talk about your provocations, does it change when you rest, sit down? It may be benign, but we don't know until they go get a 12 or until they get a 12 lead and then they go get blood work done. Out of 10, what is your worst pain you've ever felt? Out of 10 being the worst pain you've ever felt, what is your pain today? And when did this start? People always forget, when did this start, okay? Chest pain and strokes, primarily, we have to know when it started. Because the hospitals are going to want to know, and ultimately we're saying our cells suffer success, and they want to see a competent provider when we go to the hospitals. Places where you get hounded the most on it are probably going to be UNM. So with that being said, we should not be transporting people with chest pain to Sandoval Regional. I'm telling you that right now, not trying to offend you or them or the patient, but if somebody's having chest pain, they need to be going to a cath lab capable facility. So if they're a UNM patient, I'm sorry, you do need to take that ride downtown. Okay, because if they find an infarct, that person's going downtown anyway. And it stinks because now we just took one more rescue out of the city. Now we're putting the stress on the rest of the crews, but we're doing what's right for the patient, and that's something that we always need to keep in our mind. Sandoval Regional does not have a cath lab, and we need to avoid it with chest pain. All right? You do have rust. If you can convince your patient to go out of network, and because they're not a pressed patient, ultimately that's okay if they're willing to do it. But UNM has all their information. So if they're a UNM patient or heart hospital, right? We have our heart hospital. Lovis Westside is also another one. Super careful with transporting chest pain to them as well. And I'm not saying this to be mean to anybody. Ultimately, it's because we're doing what's right for the patient, and that's what our job is to do, right? Can you explain NSTEMI for me?
NSTEMI. Well, non-ST segment elevation myocardial infarction. Basically, my understanding or what I'm trying to grasp over is that it's just not a STEMI. You're just basically saying that, or the monitor is saying, and the paramedic is interpreting that this isn't a heart attack. The long and short of it.
Kind of. Okay. So we're saying ultimately that there is no ST elevation, right? But there is a possibility of a heart attack, and we can't diagnose that in the field. That's why I'm telling you, somebody can be having an NSTEMI. There's no evidence of them having a STEMI on their 12 lead, but they are having a heart attack. So that's ultimately saying we do not know. We only have so much capabilities in the field with our electrocardiograms, and the only way to truly know is to get that person to the hospital and do labs and eventually get them to the cath lab. Even if somebody has a troponin level that's high, they're going to go to the cath lab just to rule that out. Because they want to get that cath in there, they want to look around, they're going to fill it with contrast, they're going to blow those coronary arteries up, and they're going to try and find that block. Common chief complaints. I think everyone's pretty familiar with the chief complaints at this point. We're looking at chest pain, right? That's a big one. Trouble breathing, fainting, palpitations, fatigue. Sometimes we don't take those serious enough. Sometimes we're just like, oh, well, have you had a long day? Were you out in the sun? Sure, we have to ask those questions. But somebody with chest pain, we need to start thinking about the cardiovascular emergency ultimately under all those other complaints. Because it is super important, and it's ultimately going to be the one that either kills them or ruins them for the rest of their life, right? Fainting. So it's in our guidelines. Everybody who faints, any syncopal episode, they get a 12 lead. That's because we do not know. Ultimately, that person lost blood supply, oxygenated blood supply to their brain at some point and caused them to have a syncopal event. And we do not know how. Sometimes it's genuinely, syncope is one of those things that's, for the most part, is an unexplained event. They don't know, but we always take it back to the cardiovascular emergency side of it, doing 12 leads and figuring out maybe there's something that we can find, whether we're doing a 12 lead or doing a thorough assessment and a history on that patient, figuring out what kind of medical history they have, what kind of medications they're taking, and going from there. So something to also keep in mind, somebody who faints, we should be asking them, do you have history of fainting? Does the family have history of fainting? Is there any people who have history of sudden death in your family? Okay, because there's people that just drop dead. And believe it or not, sometimes we can do something about it, sometimes we can't, but the only way we can get ahead of it is doing that thorough questioning whenever we're doing our assessments. Palpitations, another super important one. How many of you reach in and reach for a pulse when you see a patient? Yeah, some of us don't. And it's okay. Like, some of us are not the initial provider who walks in and approaches the patient, but if you don't see somebody doing it, maybe just when you're getting vitals, reach in, feel for a pulse. Hey, this doesn't feel regular. A lot of times, Mike Ernest, he's all about shaking somebody's hand. Hey, how's it going? I'm Mike. And he reaches over and feels for a pulse when he shakes their hand. You can tell a lot by reaching down and feeling for a pulse. Is it weak? Is it fast and thready? Is it strong? Is it regular? Is it irregular? A lot of times people, you can tell, ask them if they have AFib before you even do anything else because you feel an irregular pulse. So don't be afraid to get hands-on with your patients. Another, going into thorough assessments, palpitations is number one for cardiac. Do you feel like you're having like a fluttering or palpitations, like your chest pounding out of your chest, or your heart pounding out of your chest? If they say yes, then we got to get into a little bit more thorough questioning, all right? Have you taken, do you have anxiety, lack of sleep lately? What kind of medications are you taking? I can tell you right now, if I'm taking some sort of corticosteroid, my heart is coming out of my chest. So keep that in the back of your mind. Drugs, anybody who works in 10s and 2s district, for sure you're going to see methamphetamine use. Sometimes they'll have chest pain with it. Cocaine, people who smoke, and believe it or not, hyperthyroid. Hyperthyroid is going to affect the body significantly, getting back into hormones too. There's so many things that could be going on, so we have to keep that open mind when we're assessing these people. Patients may also report feelings of impending doom. If you've been in the EMS game long enough, you've all witnessed it, and it kind of puts you on the back of your heels a little bit, because we've all been taught from basic, if somebody has impending doom, take it seriously, because usually something's not going well. So let's trust the patients. Let's give them the benefit of the doubt and take everything serious. Because if we do that, going back to our med legal talk this morning, we're taking all the risk and liability out of our hands by doing everything we possibly can to help that patient. Nausea and vomiting, trauma involvement, that's going back to our thorough head-to-toe assessments. If we're suspecting trauma, we should always be doing a head-to-toe assessment, but if we're suspecting trauma, that head-to-toe assessment just got a whole lot more thorough, right? Hypoxia, poor perfusion, I don't think we need to get too deep into it, but somebody has a low oxygen saturation, they're having a perfusion problem too, okay? Ask about medications, we already talked about that. What kind of medications should we be asking about? Ultimately, cardiovascular emergencies.
Like maybe hypertension,
Good, yeah, so ACE inhibitors, beta blockers, good. Big one that we miss, and it's in the field a lot, calcium channel blockers. Especially keeping in mind when you're looking at AFib RVR. People take calcium channel blockers, we hit them with, or even taking beta blockers, and we hit them with a calcium channel blocker, we just dump their pressure, and they might have a syncopal event on us, right? ACTZ, furosemide, all those things are super important. We're talking about cardiovascular emergencies. The statins, all the lipid medications. If people have those medications, there's some sort of cardiovascular thing going on, or at least the doctor thinks there is because they've had something in their past that has led that doctor to prescribe that medication to them. So anticoagulants are the biggest ones, right? We think about AFib or possible strokes. They're worried about a clot for the most part. So we need to make sure we're keeping that in mind when we're doing these assessments. Yeah. That's a long list. Can we keep that all in mind, right? We're going through, we're assessing somebody. We all know this comes with time and experience on the floor. So when we're assessing somebody, sure, we want to keep this in mind. But we also, when we're talking about cardiovascular emergencies, sometimes we got to stop thinking so big, and we have to get back to our focused assessment and focus on what's at hand and what we can treat. So most of the time though, you go pick up a patient from a facility, they'll probably have every one of these listed in their medical history along with every medication to treat it. So that goes back to our patient history, that we need to keep that in mind when we're assessing this patient, because if this person's in a lethal rhythm, or they have some sort of infarct, or they have something funky on their 12 lead, there might be a reason for it, and it may just be because this person took way too much of all these medications, and they're all starting to get that synergistic effect, right? All right, so we got through our primary, we're in our secondary, we did all the questioning, but what is something that we want to keep in mind, and what's ultimately our job, especially the intermediates and up, for these patients? Anybody? What's that?
Get them to an appropriate facility.
Sure, get them to an appropriate facility, try and identify the life threats, have a good story, and ultimately we're trying to keep in mind all those higher level of thinkings, right? Their preload, their cardiac output, especially when you're talking about shock. We can treat that patient, but we don't want to make sure we're treating that patient that's going to continue to keep them alive. This is something I feel like people are pretty good about catching for the most part, but that goes back to your head to toe. If somebody tells you they have no cardiac history, but they have obvious signs of scarring on their chest, like they had an open heart surgery, we need to get a little bit more thorough into re-questioning this patient, right? But that also goes to who's on scene, who can I ask that might know this medical history, because that person may just be at the point in their life where they don't care, and we've all seen it. So utilize your resources. I can tell you nitroglycerin patches, I haven't seen them, but if somebody has a low blood pressure and it's unexplained and they have cardiac history, we should look for it. Okay, most people take tablets, some people take the sprays, but let's keep that in mind. Let's feel for a pacemaker. Usually it's on the upper chest. So let's feel around, put some hands on, palpate, looking for chest enlargement. What are we looking for in chest enlargement? What is the indicator somebody has like a barrel chest? COPD, yeah. So we're looking about emphysema, bronchitis. So let's keep that in mind. So we have our monitoring devices. We have our 4 leads, 12 leads, CAPNO. So utilize our CAPNO. I feel like people are, ever since the CAPNO presentation we had CEs probably 2 years ago, They haven't been able to keep them in stock. Keeping Sammy, making him earn his paycheck.
They're not cheap, boys.
Yeah. And pulse ox, right? I always see people throw a blood pressure cuff on and get a 12 lead. Throw that pulse ox on right away too. Let's get our baseline vitals right away. Good. And this is some of the stuff that actually Damien touched on in shock, so you guys might get a little double whammy here. But going back to pulses, so feeling a central pulse compared to a peripheral pulse, seeing if they're regular, see if they're the same, right? Seeing if they're the same strength, see if they're the same regularity, and then your pulseless paradoxus. And this one's super hard to, it really is super hard to tell. Like we put all these big words in front of things and we say we should assess it, but it's a drop of at least 10 millimeters in your blood pressure, and ultimately it's hard to tell. What do we do? Let's be honest here. We see a blood pressure we don't like, what do we do?
Learn it again.
Hit it again, okay? So that's where we start getting to the point where we probably need to take off the automated blood pressure cuff and we need to start getting a manual blood pressure. I know nobody likes to do it just because it ties up hands. If you need to bring somebody with you to do it, bring them with you. Many hands makes light work, so let's utilize our resources and utilize everybody. Everyone's a provider that shows up on scene with us, and let's utilize them because they're all really good at what they do around here, okay? And then yeah, looking for change in pulses. So that's going back to, we're looking for cardiovascular emergencies. We're thinking about the aorta, aneurysms, dissections. Sometimes people have those things going on with them, and there is no signs or symptoms that direct you to it. So sometimes just having a wild hunch and switching your blood pressure cuff to the other arm and reaching down and feeling bilateral pulses might be the change that that person needed for facility to get them the best outcome. All right, so normal blood pressure, 120/80, and then stage 2 hypertension, probably in stage 3 right now, 140/90. So let's be realistic about blood pressures. We all try and deem every number should be this way, but ultimately most people's blood pressures are roughly in the 130s, over 80s, and anything higher than that, especially if they normally have a really good blood pressure, there should be a hunch. If their blood pressure is low, even bigger hunch. If somebody is hypertensive and it's 170s systolic and our maps are ridiculous off the charts, then we're concerned, right? Can somebody tell me what a normal map is that we're looking for on our patients? 65, yeah. So 65 is ultimately where we want to be. 70 is ideal, but we do not want to be dropping down below 65. If we're going below 65, then we start talking about narrowing pressures or widening, right? We got to think about what raises blood pressure: anxiety and pain. Somebody has injured themselves, maybe they fell, broken arm. We should not be asking them if they have high blood pressure, right? I mean, at the end of the day, their blood pressure is high. We shouldn't be telling them, hey, you need your blood pressure checked. I've seen it. That's why I'm saying it. Like, that person's blood pressure is high because they just fell and broke something. Pain raises your blood pressure. And then, yeah, I feel like I'm jumping ahead. I know this PowerPoint pretty well, huh? I'm answering all the things before I get to them. Heart sounds. How many of you have listened to heart sounds? Good, yeah, most of the medics. So we have a stethoscope, and anytime you listen to a kid's lung sounds, what do we hear? If we listen to a kid's lung sounds, what do you usually hear first? Yeah, that heart is thumping. So we always get a good sound of the kid's heart. How many times do we do it on the adults? Never. Nobody ever does it. Think about that if you're thinking about cardiovascular emergencies. You're listening to lung sounds already. Reach down, because any cardiovascular emergency, we should be listening to lung sounds. Because if we're suspecting CHF and left-sided heart failure, right, and right-sided heart failure is always there if you have left-sided. So we need to make sure that we listen to lung sounds, make sure there's no pulmonary edema, and why not just go up a little bit further and listen to the patient's heart. We won't get super deep into it, but ultimately you're listening to the AV valves in the heart between the ventricles and the atria, and we're listening to that lub-dub sound, that S1. You should hear those valves opening and closing. If you hear anything abnormal, then you know something might be wrong. So if you're not hearing lub-dub sound, you're hearing an extra sound, then maybe you just note that to the doctor, and that might change the outcome of that patient. So we're on our way to the hospital. We're in that reassessment phase, and maybe we're trying to catch something we didn't catch necessarily in our primary and our secondary assessment. And something to notify on that is our reassessment is basically starting from the top. We're going impression, looking at the patient, skin color, airway, breathing, circulation, and then reassessing all his vital signs, doing another thorough head to toe. And I understand, sometimes we do not have time to do a thorough head to toe, and that's completely acceptable. We're doing a lot, especially for treating this patient. We're giving them medications, we're doing meds, we're trying to get history. But if you have the time, let's do a thorough head to toe, make sure we didn't miss nothing. Because a lot of times just looking at the patient's body and palpating can tell us a lot about what's going on with that patient. All right, kind of where we want to be. Okay, electrophysiology. Conduction system specializing in conducting tissues propagates electrical impulses to the muscular tissue. Okay, kind of where we started off in the beginning. That heart is a big muscle. We have a lot of conduction going through it. We have our, I won't touch the screen actually because I know it does weird stuff, but we have our SA node, which is ultimately our primary pacemaker. It's up in the right atria, and then you have your AV node, which is in the lower part of that atria, and all that conduction is going down, it's coming down, it's slowing down, going through that septum, internal septum, and then it's going down through your bundle of his, your Purkinje fibers, and you're getting into your bundle branches, right? So when we talk about the medics and they're saying AV blocks, left bundle branch blocks, right bundle branch blocks, it's coming from these portions of the heart. And I'm trying to keep this super simple. I don't want to make it complicated. Just so when you guys hear these things, I want you to think like, okay, that's what they're talking about. So that left bundle branch is over here, right bundle branch over here, and it's ultimately that conduction system that's going through the heart muscle. Okay, and that's what's creating that conduction, making that contraction of the atria and ventricles, right? Good. So, autonomic nervous system. This is where things kind of get a little more exciting. Sympathetic nerves, right? Anybody tell me what our sympathetic nervous system is, besides Tim?
The fight or flight.
Fight or flight. Thank you. I know you know it. So our fight or flight. And ultimately, so we think about epinephrine and norepinephrine. So along the lines here, we will be carrying norepinephrine or levofed, and it works on our alpha receptors, basically, which is your constriction of your vessels. And what this medication is doing is the same that our natural production of norepinephrine is doing, just at a more drastic effect. And it helps increase and speeds up cardiac output. All right, who can tell me parasympathetic nervous system?
Rest and digest.
All right, Tim.
Rest and digest.
Yeah, rest and digest. Good. So the thing about parasympathetic inhibitory nerves, sending through the vagus nerve, which is which cranial nerve?
No, 10.
10. Good. You're killing it, dude. It's like you just went through medical school or something. And it innervates functional areas, decreased heart rate. So, anybody seen atropine given to somebody with a low heart rate? No? Yeah, Tim? Of course. So we're giving atropine, and it's working on creating that sympathetic effect by increasing the heart rate, hopefully creating better contraction, and which ultimately will increase cardiac output. If you think about somebody who vagals out, how many times have you guys heard somebody say, or you heard somebody on scene be like, I think they just vagaled out. They're using the bathroom, or like, we don't really know at the end of the day, but it's ultimately that Valsalva maneuver. How many have seen people in SVT? And what do we make them do before we give them medication? We make them blow into a syringe, which is blowing up against that epiglottis, the closed epiglottis, which is stimulating that vagus nerve, which is hopefully bringing that heart rate down and creating that parasympathetic inhibitory nerve to work on that heart, right? So we're trying to get that heart to reset, slow down, and ultimately solve the problem that we don't necessarily need to solve. It can solve itself, right? Going back to the aortic arch, right? It's also the carotid arteries. We have baroreceptors, sensors composed of specialized nerve tissues, and detects change in blood pressure, generates reflex response, the sympathetic or parasympathetic division in the autonomic nervous system. And we were talking about, far left, we were talking about vasopressin earlier, but we start talking about blood pressure and trying to get your body to respond, but they have vasopressins and all these pressors that they use at the hospitals. If anybody's done interfacility transport, you've probably seen them. Most of those guys have worked at Station 2, maybe 10 for Rust, but they put these people on these pressors, which is basically naturally, most of the stuff's naturally occurring hormones in the body that create the same effect that body's hormones would create, but just at a higher and Jurassic level, so we can keep that pressure up, keep that conduction going, and basically keep that person alive till, number one, it can work for itself, or number two, they can figure out the problem so they can get that patient to operate at a normal baseline. Same thing for chemoreceptors. We won't dive too deep into it, but basically and ultimately the same thing, okay? Good, so EKGs, electrocardiograms, just a fun fact. Cardiologists will probably cringe and not say it to you, but if you call an ECG to a cardiologist, they might cringe because old terminology and old heads in EMS and cardiology believe it sounds too much like EEG, and basically it's figuring out the electroactivity of the brain, especially for neurologists. But EKGs are preferred if you talk to a cardiologist, and you might win them over a little bit with some brownie points. So we're talking about lead groups here. We have limb leads, precordial leads, and augmental limb leads. And if anybody's looked at a 12 lead or handed one over to a medic, you've seen these on our 12 leads, especially from the Zols, okay? So going to the Einthoven's theory, every time the heart contracts, electrical energy is emitted, okay? That's why heart contraction is super important. So we have lead 1 attached to the, it goes from the right to the left arm, lead 2 between the right arm and the left leg, and lead 3 runs between left arm and left leg, as you see in that picture. So you have it up top, across, and left leg up to left arm. And I'm telling you right now, I genuinely believe if you were doing a 3-lead or a 4-lead, you should be doing a 12-lead. All right? The only time you should ever need a 3-lead, and it's usually the medics who are needing it, is if that 12-lead did not give them a long enough strip for them to truly see the regularity or maybe see some sort of block in that 3-lead. And they need to figure out if this person has a AV block, or if their rhythm is irregular, or they need a little longer strip to determine certain intervals in that 12-lead. So for those of you guys who do 12 leads, and I think it's super important, those of you guys that do it really good, us medics, we love you. Those of you that don't do it that good, please keep working on it, and we'll love you too. But if you're doing a 4 or 3 lead, you should be doing a 12 lead ultimately, and because you're halfway there. Let's just see the full picture of the heart and figure out what's going on with this patient. Precordial leads, unipolar. Hopefully you guys can see, yeah, they're pretty good. So we have our Wilson's terminal. That's our basically our central access point of the heart, and that's what it's looking at. We have all these leads looking into it. You have your 3-lead, you have your augmental leads, and then you have your precordial leads. And that is giving us all angles, the inferior, superior, inferior laterals, and ultimately every angle from lateral to septal. And it gives us a picture of the atrias and the ventricles, and we're looking at all those coronary arteries that are going around the heart, so we can figure out, and a lot of times if we can figure out what side of the heart it's coming from, we might be able to figure out why we're getting that rhythm, that AV block on that patient, and maybe why they're going into these life-threatening rhythms ultimately. Can we do a lot about it? Yes, and in context, ultimately they need to go to get to definitive care, and that helps us determine that. All right, so got another good picture of ultimately your heart here and where it's placed and all your leads. All right, good. This one's a good one. So if you ever hear a medic say, hey, I need a right-sided, this is what they mean. Sure, V4R is great. Does it give us the full picture? Not really. So you got V1, it's in the 4th intercostal space, and V2 is, they're in the same places they normally are. And then you go do your, ultimately your right-sided is the same thing you do on the left. You're going from our 4th intercostals to our 5th, and then we're putting our 3rd in between, our V3 in between V1 and V4, and then we have V5 between V6 and V4, okay? It is super important to make sure that we do these, especially when we're suspecting right-sided involvement, because nobody should be getting nitro if they have some sort of right-sided involvement. And that's that right coronary artery, it's affecting the preload, and we don't want to dump this patient. And ultimately those who are intermediates and paramedics, we need to have an IV in place, and pretty fast too, especially for suspecting right-side involvement. Even if we don't give nitro, something could happen throughout transport. Posterior leads, just call this 789. So you're doing, there's an acronym, because we all love acronyms around here, it's called PAILS. You have your posterior, anterior, inferior, lateral, and your lateral follows your posterior if you're thinking lateral involvement, so you're getting to your posterior 12 lead, 7, 8, 9. So basically you're just taking 4, 5, and 6, and you're adding them to that 5th intercostal space, and you're taking that V6, you're putting it 5th intercostal space to the left of the spine, and then you're putting V4 between and V5 in between V6 ultimately. And this is super important for placement once again. If you guys know how to do this, it creates that treatment for that patient to happen a lot faster, gets those 12 leads printed out quicker. I will tell you guys, if you are printing them, because we all know, I know I'm guilty of it, I print off so many 12 leads if I'm expecting cardiac involvement. Keep a pen on you and note that 12 lead. Hey, this was my 789, this one was my right-sided 12 lead. That way when you have them, whether you want to keep them for your records, ultimately you should print them off for the cardiologist or the hospital, and that way they know what those leads were. And then you can circle, if you wanted to, what you find on them as well. So baseline, so for those of you still kind of learning, sure, do we expect you to interpret 12 leads or 3 leads? Not necessarily. Should you have a baseline understanding? Sure, right? So we have our baseline. It's ultimately the electrical impulse, the electrical silence of the myocardium. And that baseline is where we're going to determine whether there's elevation or depression. And then we can also determine whether there's deflection or above the baseline or below the baseline. So, and those things are going to be indicators for us to treat that patient, because we can see electrolyte imbalances on those patients. We can see neuro involvement on those patients. Somebody had a seizure, maybe some head trauma. And then obviously we're going to see cardiac involvement, whether it's ischemia of the heart or there's some sort of injury. There's just a fun little look at a rhythm there. So this one's super important. Those of you guys running BLS buses, ILS buses, we thought about our baseline, right? It's that line that goes straight across, and these are ultimately even going across for our electricity. Our QRS, our P waves, and our T waves are going to be a little bit, you're going to see that deflection in them. You see our repolarization and our depolarization and repolarization in our QRSs as well. So this is where you start thinking about, okay, is this person having a heart attack? Well, ultimately you can't interpret it. Your monitor will do that for you, and I swear every one of those freaking monitors interprets anterior infarct. And who knows, it might just be seeing those Q waves that are ultimately a precursor indicator that's picking it up. I don't know. At the end of the day, this person's having chest pain, I'm taking them to the hospital. Hey, Kathy. So we want to make sure that we're looking at this J point here. So it's our QRS. We're at our S, this is our J point, and that's our transition for our ST point. And we're looking at any elevation there, especially more than 1 millimeter or one small box, and 2 or more leads. We should be considering some sort of cardiac involvement or ST elevation, okay? And I want you guys to keep that in mind. You guys are all very competent. If you see these big tombstone looking things on your 12 lead, there's probably something going on, some cardiac involvement. Get a medic coming, rendezvous, get MedCom coming. That way we can start treating this patient and get this patient where they need to go. But ultimately, you guys need to do your job. Chest pain, aspirin, make sure they don't have allergies, right? Oxygen if they need oxygen, if they're not perfusing, or they're hypoxic. And then let's treat that patient the best we can, get a thorough history while we're transporting this patient. T waves, this one's super important too. If you start seeing inverted T waves, we're suspecting it could be a precursor. Number one, it could be prior cardiac history. Maybe they have an injury to their heart. If we see some super deep ones, it could be a precursor. This person's about to have a myocardial infarction. So if you start seeing inverted T waves, all right, there's something going on. I need to figure out what's going on. Hey ma'am, hey sir, I think it's a good idea you go to the hospital. We see some stuff on your EKG that doesn't look normal, okay? So you don't have to be a medic to know this stuff. Yes, to interpret it, you do, put it on your chart. This is pretty basic. Like, hey, that doesn't look normal. I think you should go get a second opinion. Second opinion's never hurt, right? Rhythm regularity, your R to R intervals. So that R wave is ultimately where we measure our regularity in our heart and our rhythm. So if that is irregular, which we'll look at some here in a minute, then we should be questioning maybe something else is going on as well, especially if we don't have history of irregular heart rates. So keep that in mind. Your distance between the R waves should be regular. If you want a simple way to measure it out, take another piece of paper, pull it off, take a pen, measure one, mark both tops like this, paper here, mark, go to the next one. Is it regular? Is it the same as the first one? If it's not regular, guess what? There's probably something going on, especially if they're having chest pain and they don't have history of cardiac history. There's a irregular rhythm, pretty ugly. What are we thinking? Irregular kind of rhythms? AFib is a good one, yeah. It's probably the most common one we see. So let's keep that in mind. We see something like that, especially if they don't have history of AFib. What are concerns with AFib? Why are we so worried, especially if they don't take blood thinners? Clots, yeah, so they can break off a clot, it can end up as a stroke, and then we got even bigger problems. So let's keep that in mind when we're assessing these patients. There's a regular, irregular. Any guesses on a regular, irregular rhythm? Yeah, so heart blocks, like Winky box. Usually those basic AV blocks, you'll see a lot of it. This person looks like they may even have started a bundle branch. But yeah, so let's keep that stuff in mind. Normal sinus rhythm, let's keep it basic, 60 to 100. Uprighted P waves preceding each QRS, and we should be looking at that. Do we have P waves? Is it regular? Is it irregular? What do my T waves look like, right? Are my T waves upsloping and drastic? That could be an indicator of a heart attack. We just haven't got the ST segment going on yet. Sinus Brady, super concerning, especially if they're symptomatic. What if somebody is a young male or young female and they're an athlete and they have a heart rate of 52? Are we concerned? No, we're not super concerned. People who are athletes, especially if they're young, even older athletes, they'll usually have a slower rhythm, and that's not unusual. Also, if you're getting like a first-degree block, pretty common in healthy adults, especially athletes. I swear to you, people who do like ultra marathons, things like that, you're gonna see those first-degree blocks and super Brady rhythms. Some people will hang out even in like the high 40s. But if that's not normal for them and they're having symptoms, let's treat and transport. Sinus tach, 101 to 150. Can we have a sinus tach above 150? What is it above 150? Sure. So we have always been taught, super fast rhythm above 150. If it has P waves, it's sinus. Okay? So if somebody has a rate of 178 or 180, if I'm working out, it's probably 190. Doing cardio, which I do so much of, then we're ultimately concerned, right? But if it has P waves, I'm not super concerned of SVT. I'm not treating SVT unless they're symptomatic. If it's narrow and it's fast and they have symptoms, sure, we should be treating it. Going back to those vagal maneuvers that we were talking about so much earlier. P waves, P waves, P waves. We're talking about a fast rhythm above 150. Let's see if it has P waves, okay? Sinus dysrhythmia, sometimes people get concerned about this if they're not familiar. It's usually pretty benign. Usually it's just based off of inspiration or expiration, where that person's breathing and that EKG was just caught whenever that person is taking deep breaths, and you just have a little bit of an irregularity, but for the most part everything else is regular, okay? Sinus arrest. This one is one of those things where it's usually pretty benign, but if they're having symptoms, something seems irregular, then we do take it serious, okay? But it's pretty rare you see this, but I will tell you that you do see sinus dysrhythmias more than you see sinus arrest. It's based off of somebody's breathing. SVT, so we talk about 150 to 180 beats per minute. P waves are obscured, and T waves are the preceding beat, right? So it's more predominant. And we all know how to treat SVT, I think, at this point, for the most part. If you've had some time in the field, let's try vagal maneuvers. If they're unstable, what are we doing? Synchronized cardioversion. I will tell you guys, those of you that are medics and you mess with monitors, when you're doing your monitor checks in the morning, make sure that your milliamps and your beats on your pacing is set correctly. Because if you turn it on and somebody had previously messed with it, it will be set to milliamps at a high rate and a higher rate for beats. So just something I've picked up on messing with it quite a bit. Yeah, so we're talking about the seriousness of the symptoms, okay? Somebody's having palpitations, they're pale, cool, diaphoretic, and let's determine if it's regular, irregular. Let's figure out what's going on, especially if we have a medic coming. Let's try and get as much information as possible, give them the best story we can, and same if we need a load and go, let's make sure we have the best story we can provide to that hospital, whoever we're getting turned over to. History taking is key. They can't see what's going on at scene. They don't have the bystanders to question, especially if the family's not coming. So let's keep that in mind whenever we're doing our assessments and gathering information along with the medications they're taking. Over that. Delta waves, we also have to be super careful. If somebody has a history of WPW or LGL, then we need to take that serious. I want to emphasize this again. If somebody has this history of WPW or LGL, we need to know what's going on, because pushing adenosine on this person may throw this person into a lethal rhythm. So those of you that don't know what that is, now you know. You're going to see upsloping on your Q waves. It's what we call a delta wave. And the WPWs and the LDLs are a very serious cardiac history. And most people that have it know it. But if you see something unusual with that upsloping and a delta wave, let's get a medic coming. Or what is our other option? What can we do if we're running a basic bus or an intermediate bus and we're not sure about a rhythm? What do we have capabilities on our monitor?
Just
Transmit it. Let's transmit it before we call a radio report. Let's get a radio report. Hey, I transmitted my 12 lead. I'm suspecting this, or I don't know what to interpret. I'm running a basic bus. This person's having chest pain or palpitations. Can you have a doc look at it and give me an interpretation and treatment for my licensure? Docs usually know what you treat at your licensure for basics, intermediates, and paramedics. Most of them are medical directors for other areas, especially Sandoval Regional and UNM. You have a lot of different medical directors around, okay? AFib, we talked a little bit about AFib, we won't beat it up. Everyone should be pretty familiar at this point, but let's keep in mind, is that person taking blood thinners? Are they stable? And do they have history of AFib, okay? Especially people that have history of AFib, or people who I see it so often, people who are having respiratory emergencies. A lot of times I'll see them in AFib RBR. It's very common. So if you find AFib RBR, then we have to figure out, is it the AFib RBR that's causing the respiratory emergency, or is it the respiratory emergency that created the AFib RBR? So let's keep these things in mind whenever we're assessing our patients, because there's no black and white answer for anything, right? Atrial flutter, you'll see F waves or sawtooth pattern. So if you see a regular rhythm, but you see this sawtooth pattern, that person is in a flutter. Looks like a picket fence, and symptomatic, not symptomatic, we need to know that, okay? And that's the kind of stuff that we're going to turn over to the hospital and determine how that person gets treated, especially if we're working at a basic or intermediate level. Junctional escapes, if you do not see P waves, and this rhythm looks somewhat regular for the most part, and there's no P waves, that person is most likely in a junctional rhythm. Junctional rhythms are usually between 40 and 60, and without P waves. If they're 60 to 100, it's an accelerated junctional. Anything above 100 is tacky. Idioventricular rhythms, I've seen this a lot on conscious patients. Ultimately, this person that I was transporting was pretty asymptomatic and just was going into IVR. It was pretty gnarly. And then I watched the cath on him, and that guy was all over the place with his rhythms. So we got to take it serious. IVR is also something that you'll see a lot in cardiac arrest, and it's usually a PEA at that point, and it's super hard to palpate a pulse. VTAC, I think we're kind of beating up the VTAC and VFibs today. Somebody can be alive with VTAC. It's usually symptomatic. Somebody who has a gnarly left bundle branch could look a lot like VTAC. We start talking about left ventricular failure, and somebody with left ventricular failure, a lot of times they'll have pulmonary edema. So we might get zoned in on respiratory. Let's decipher whether that's cardiac wheezes or if that's some sort of COPD that's causing this, okay? That's where our thorough history gathering comes from. If somebody's in VTAC, they are going to need to be treated, and we do need to make sure that we get a medic on scene or rendezvous if we have the time. If they're stable and you're going to get to the hospital before a medic can get to you, let's load them up and get going, okay? This one's sorry, no it's not. That one's monomorphic, means it's pretty regular. This is polymorphic, and it's a pretty ugly rhythm. Pretty rare you're going to see somebody that is conscious with torsades or polymorphic VTAC, but it's pretty deadly. This person's going to need some cardioversion and or some deep defibrillation. It's going to be probably pretty hard to cardiovert this patient. This person's going to need some electrical therapy. VFib, person not going to be alive with VFib. They're going to be pulseless. Pretty common finding in patients that are bystander CPR or early. We get to them early and we can get pads on them, and we will be shocking this patient, but it is pretty irregular and ugly. And there's another VFib. That's coarse VFib. I'm sorry, fine VFib, and it almost looks like asystole. I've seen this once or twice. Thankfully, not thankfully, but the person had a DNR, so there wasn't much that we did for him. Yeah, there you go, VFib. Pulseless VTAC. We need an automated external defibrillator. Let's get the AED going. If we have a medic on scene, we can do some manual defibrillation interpretation. And there's your asystole, okay? What is asystole? Cardiac standstill, right? Ventricular standstill. We do not shock asystole as much as people want to. I know we say shock it till we recognize it. I feel like you should recognize that one pretty good, okay? So let's continue considering the circumstances if we're on a code, and we need to go through our guidelines. How long has this person been down? Bystander CPR initiated. When was the last time this person was seen, okay? Any questions so far? Cool. All right. PEA, you could have irregular rhythm, you could have sinus rhythm, you could have junctional IVR. It's a noticeable rhythm that we can interpret, but they do not have a pulse. Okay? We do not shock PEA, and there's not a lot we do for it. We basically treat it like we treat asystole. And there's multiple things that could be causing it, and that's up to, at that point, having a medic on scene and determining our path of treatment based off of our history gathering from anybody that was on scene, if it was witnessed or a family member, right? All right, code blue. Just kidding, that's it.